to today's topic. Thank you very much, sir.
All right, thank you, our moderator. I don't know, I want to confirm whether we have muted everybody. Okay, I think, let me assume the screen is muted. Then the second thing, can you see my screen, the one I'm sharing right now?
Yes, sir, we can see your screen, sir.
All right, thank you. Thank you, our CPAN Oncology group, for giving me this opportunity to share the little I know about this important topic. Perhaps that we are starting late, I think it will be nice to make the presentation as fast as possible. I like to start my presentation with expectations always, so that at the end of the day, I will not disappoint you much. Presentations related to CPAN are supposed to be interactive, so that we can share our experiences in various for various years, so that we can share our experiences and enhance our practice capacities. Then CPAN presentations supposed to be patient-centered. So as much as we have a lot of theoretical knowledge, we want to focus on the patient. How will the patient get better? Hence, we make a lot of emphasis on the practice. I'm sorry, I did not intend to cover every aspect of breast cancer management, but at least I wish I can share some interesting aspects. At the end of the day, I hope to add some value to our oncology, i.e. the breast cancer practice skills. So I have some learning objectives. At the end of this presentation, I hope we will appreciate the public health impact of breast cancer, especially in sub-Saharan African regions like Nigeria, to appreciate the management protocols and options of breast cancer, and finally, to appreciate the clinical pharmacist perspective in managing chronic diseases like breast cancer. Now, this presentation, I would like you to look out for these three different captions. I divided it into three different parts. What we know about breast cancer, then what we do as clinical pharmacists, that is the second part, then how we do the things we do. So I just created this so that at least we'll be expecting this. The part one is the longest part, but it's also the most important part, because without the knowledge, we cannot do the things that we do well. This picture shows a woman probably having a self-breast examination. Okay, so by the time we see this, you know we're referring to breast cancer. Because of the late commencement, I will probably move faster so that we can just take some key messages, and at least before we get tired. So hopefully in the next 30 minutes, we should be through. I don't know whether we can make it that way. So in understanding the public health impact of breast cancer, we can see that breast cancer has a very high global incidence and mortality. In fact, female breast cancer has the highest of, by 11.7%, but the mortality globally, breast cancer is about the 5th or 6th. But when we come to Nigeria, we realize that still breast cancer has the highest incidence and also the highest mortality. So unlike the global statistics, where breast cancer has about the 5th or the 6th in terms of mortality, in Nigeria, breast cancer is the most common malignant disease, and it accounts for the highest number of mortality. That shows you how much impact that negatively this breast cancer has in the public health. Now, to understand the management, especially in clinical pharmacist perspective, we need to understand some things. First of all, the staging and classification. Before you manage, of course, you need to know it is the breast cancer, but what kind of breast cancer? Because there is no single route to the management. Hence, normally the classification, we start from the origin. If we look at it, you can see that this is a structure of breast. Breast has three major structures: the lobules, the duct, and the fat tissue. So breast cancer can originate from the lobules or from the duct, otherwise called milk duct. So in that case, you could hear things like lobular carcinoma or ductal carcinoma. If we come to the right, that cancer can even spread away from the original, from the structures of origin, even to the lymph nodes. Hence, the cancer can be invasive or non-invasive, even though they originated from the lobules or from the duct. So if they are non-invasive, that is where we hear things like carcinoma in situ. So in that case, we can have lobular carcinoma in situ or ductal carcinoma in situ based on the two origins. Then if they are invasive, that is confirmed they are diagnosed to be cancer, then it will be in this invasive ductal carcinoma or invasive lobular carcinoma. So now we understand the origin and some classification based on that. The second part now is that, okay, there is this TNM classification, where tumors are classified based on the tumor size, nodal involvement, and presence or absence of metastasis. The numbers there reflect the severity. The tumor size can be 1, 2, 3, 4, or up to 4, depending on the size, how many centimeters, whether they are attached to the chest wall or not, how many lymph nodes are involved, 1, 2, or 3. Then metastasis, 0 is for no metastasis and 1 is for metastasis. Hence, we can see that we can now say that we have stage 0, 1, 2, and 3. Stage 0 is basically carcinoma in situ, whether ductal or lobular. That means there is no invasion. Okay, it is non-invasive. But stage 1, the small tumor, and that is how stage 1 and 2 are all called early breast cancer, all the 3. But stage 1 and 2 are the ones that are confirmed because they are invasive, confirmed to be cancer. But stage 0 is more of what you call lump. It's just carcinoma in situ. Then stage 3 is what is called locally advanced breast cancer, while stage 4, that is metastasis. So all we are saying about the TNM and also the tumor size and otherwise, you can see that you have the early breast cancer. You still have subclasses. This is just the easy way of classifying it. But when we go deeper, you can see that even in stage 2, you have stage 2A, B. Stage 3, you have A, B, and C, according to severity, up to that stage 4, depending on the tumor size, how many lymph nodes are involved, or with or without metastasis. So pictorially, you can see that stage 1 is showing just a kind of lump. You have the cancer in one place, no lymph node. Stage 2, it looked like lymph nodes are involved around the axillary. Stage 3 shows that there are more lymph nodes involved and the tumor size has increased. And stage 4, it shows that there is metastasis here to the brain, here to the lung, here to the liver. Then it has moved away from the site of origin. Yes, If it was a physical presentation, perhaps we will have sampled some opinion that, okay, from this picture, what kind of cancer, what stage do we think it is? So if you look at it, it look more like stage 3 breast cancer. All the pictures 1, 2, 3, and 4. That is how it looked like. Stage 1 and 2, probably the size will not be up to this. There is another important classification, that is molecular classification, based on what we call immunohistochemistry, where we check the molecular subtype that is highly tied to the prognosis of the disease and also the treatment decision. And that is where we have what we call Lumina A. Lumina A is basically when we have estrogen receptor ER and PR receptor progesterone receptor positive expression. But human epidermal growth factor receptor 2 is negative, that is HER2. Also, another Ki67 protein is low. All these things, they are markers of breast cancer. Okay, they are molecular markers of breast cancer. But when we come to Lumina B, what you call human epidermal growth factor receptor may be negative or positive, but the Ki67 may be high or low. Then you have HER2 positive, that is human epidermal growth factor receptor positive. Then you have the triple negative breast cancer, basal-like, whereby the ER, PR, and HER2 are all negative. So they have different prognosis and different treatment protocols. Hence, so since we just have that background, we can now go to management. So what are the things we need to have in mind in managing breast cancer? Do we need the patient age? Of course, yes. How about the stage? Yes, because the treatment depends on the stage, whether it is early, locally advanced, or metastatic. Molecular subtype, yes, because sometimes you need targeted therapy. Comorbidity, of course, as clinical pharmacists, we know managing comorbidities is one of the places that we shine a lot. Hormone receptor status, of course, I2 positive status, patient choice, of course, because everything is about the patient, availability of medicine, cost of the medicine. You can have all the plan, but if the patient cannot afford it and you cannot give him for free, then definitely there is nothing that can be done. So normally chronic diseases like this have their own guidelines or protocols. So I just mentioned 3 major guidelines in breast cancer management. We have the National Comprehensive Cancer Network, American Society of Clinical Oncology, so NCCN, this one ASCO, so I will mention it as such. Then you have expert opinion like the St. Gallen International Consensus on Breast Cancer. That is one of the major specific guidelines for breast cancer, St. Gallen International Consensus. You have publication regularly about specific cancer subtypes. Now, how do we start? When we have patients with breast cancer, then normally you take history, physical examination, of course, ultrasound, histopathology. Histopathology is where you actually diagnose, where you see histopath result conclusion, invasive ductal carcinoma. From that invasion, you know it is cancer. Ductal carcinoma, the origin is from the duct, or invasive lobular carcinoma and others. Then the IHC, that is immunohistochemistry, where you check the markers, the biomarkers, ER, PR, estrogen receptor, progesterone receptor, whether the cancers, they have estrogen receptors on them, progesterone receptor on them, human epidermal growth factor receptor, this is another receptor, or Ki67 protein. Then another one we do is the BRCA1 or BRCA2 gene. Normally these ones, they normally show whether there is family history or not. Then, of course, we come to full blood count, serum area, electrolyte, urea, and creatinine, LFT, checks, X-ray, echo, cardiogram. Another quiz. Which of these can we say are diagnostic investigation, for treatment selection, or treatment monitoring? Let us mention one. Of course, histopart is for diagnosis. IHC is more of treatment for treatment selection. How about treatment monitoring? We can say that even the full blood count, LFT and the remaining ones, they are also for treatment selection, because in terms of chemotherapy, it's not every chemotherapeutic option you can take for any kind of patient. Some cytotoxic are not good for a failing liver or a failing kidney. So it depends. Ultrasound is also for diagnosis. Then for treatment selection, we can say IHC. Treatment monitoring, of course. Should we say chest X-ray? Sometimes we monitor whether there is pulmonary toxicity from the cytotoxic or not. Echo, whether there is cardiac toxicity or not. So all those ones, I think, let's move on. So what are the management options? The last time we had our meeting in September, we talked about general management of cancer, where we say we have the surgery, we have the radiotherapy, targeted therapy, chemotherapy, targeted or hormonal therapy. Now, surgery is one of the most commonly practiced model of breast cancer management, especially in our own region in Nigeria. Why? Because patients normally present to the hospital late when the disease is already at advanced stage. That is one. Two, we have few access to oncology specialists. So mostly when you go to general hospital, secondary healthcare facility, once we have this, then they just go for radical mastectomy straight. And that is why surgery is the most accessible, perhaps the most affordable, probably. But is it more effective like that? No, it's not always that you need the surgery. Even the surgery, it depends on what kind of surgery are you doing. Is it modified radical mastectomy or just lumpectomy, depending on the stage of the disease and the benefit that you have foreseen before we choose what kind of surgery a patient should benefit from. Radiotherapy is another option. This is not very accessible. It's not even very available. It's not even affordable. So now, because of that, hardly will you see patients benefiting from radiotherapy. Targeted therapy has its own problem because many labs, not until now, many labs are not doing IHC, immunohistochemistry. Many people also, physicians handling oncology cases, don't know the importance of this IHC so that we can know whether or not we need targeted therapy. So that is one problem about it. It's either it is not available, then sometimes it is not also affordable. Some patient will prefer, for example, you just say go for IHC, 30,000 naira. Maybe they will have used it to receive 2 cycles of
Hello. Hello, pharmacist Aminu, are you there? I think he has gone offline. Probably there's a problem with the network. think there's a problem with the network. Pharmacist Aminu is offline. I'm sure he will soon reconnect.
Hello.
Hello? Please, just a little bit of patience. I'm sure Pharmacist Aminu will soon reconnect.
Moderator, do you have his slides? Maybe you could display them.
Okay,
and
right.
just go flip through them while we wait for him. If he joins us, we can then still go back and continue from where he left us, please.
Okay, right. Let me try to share the, just a moment, please.
Do we have him yet? Not yet, right?
Not yet. Not yet.
Hello.
Wow.
Okay.
Yeah, sorry about that.
Okay.
Oh,
Are you back? All right.
Yes.
All right. Please go ahead.
Okay. All right. So okay. So we're talking about management options. And we made mention of the surgery, radiotherapy, and targeted therapy with their problems. And at the end of the day, I concluded by saying that chemotherapy is the most accessible treatment option. So incidentally, as clinical pharmacists, that is where we have more interest because it involves drugs. But then we need to understand why we need or we don't need other treatment options so that the patient can benefit best from the chemotherapy. Okay, so now here are pharmacotherapeutic options. We made mention of chemotherapy. Yes, I'm not going to mention the classes of chemotherapeutic agent, alkalinizing agent, antimetabolite, and so on. I believe our pharmacology is sound. We are going to focus on patient. Hormonal therapy targeting estrogen receptor like tamoxifen. We have toremifene that also work like tamoxifen. We have the aromatase inhibitors, AIs like anastrozole, letrozole, etc. We have the targeted therapy like trastuzumab, Herceptin. I think Herceptin is the most common targeted therapy, targeting hemaepidermal growth factor receptor 2. Then you have other options. Now, let us summarize this multiple approach against breast cancer. I'm not going to take much time here because what I want to draw our attention is that we have different treatment modalities, whether it is early breast cancer, stage 1 to 2. In early breast cancer, just note that anywhere we consider you have the surgery, this BCS is the breast conserving surgery or radiotherapy, okay, as options. Then also chemotherapy, whether radiotherapy is necessary or not. Then at the end of each alternative, we have the whether the surgery is going to be modified, radical mastectomy, whether it will just be other options of the system. Then if we go to treatment modality for stage 2 and 3A, you can see that still chemotherapy, surgery, breast conserving surgery with adrenal lymph node dissection or modified radical mastectomy, and hormonal therapy plus or minus chemotherapy. Then you have other ones. So all of them, you realize that you have either surgery, chemotherapy, with or without radiation therapy, with or without hormonal therapy, that is targeted therapy. So those are the options that we played around with. Then one funny thing about this is that you will hardly see a defined rule that if it is this kind of cancer, confirm this is the kind of chemotherapeutic option that you use. Normally, you look at a lot of patients' characteristics, the expected benefit before we take decision. Then you have also special patient categories and so on. Now, in the management team of breast cancer, now that we understand something about breast cancer, and also in the management team, we have the clinical oncology pharmacist, you have the surgeon, you have the radiation and clinical oncologist, those that give the radiotherapy, the doctors in that aspect. You have the medical oncologist. Pathologist is the one that normally does the diagnosis, radiologists, oncology nurses, and others. And do you think we need psychologists? Yes. Just imagine a young lady that's undergo radical mastectomy. She needs a lot of psychotherapeutic intervention. Now we are done with part 1. Now part 2 is what we do as clinical pharmacists. My target is to finish by 9 plus or minus 10 minutes. All right, let's see. What we do as clinical pharmacists. Let me just give one scenario. 3 days ago, a 65-year-old man called me that he has been managing hypertension for at least 20 years now, and he has a large prostate. He is on tamsulosin and others, and he also has diabetes. Now, the problem is that the diabetic, he has poorly controlled poorly controlled sugar for the diabetes. That is the problem. And he's afraid that he is not improving the way it is because he has health literacy, because he's a veterinary doctor. So when he came to me, he brought all the investigations and all the drugs he is taking, including insulin. Now, he said that let him keep the investigations there aside because they are meant for diagnosis. Let us concentrate on drugs. I now say, no, I'm going to look at the investigations to know how the drugs will be beneficial for you. And what I told him that as clinical pharmacist, I will ask you now, what is the problem? We know your problem, of course, hypertension and diabetes on a background, prostate enlargement or prostate BPH, benign prostatic hyperplasia, whatever. That is the medical diagnosis. But what is the problem? I need to assess. One of my assessment, from what he told me, he urinates too much, he has this. But my assessment is that the blood glucose is poorly controlled. The hypertension was poorly managed because the echo result shows a lot of stress that the heart has been undergoing. So why am I mentioning this? As clinical pharmacists, yes, we are not physicians, but we understand some diagnostic process. We look at lab results to have an assessment of what is the drug therapy problem. Now, my assessment was there was drug therapy problem, his blood sugar control need optimization. So what did we do? I just separated the drugs. This is for hypertension, take it so time. This is for BPH, take it so time. He has soluble insulin and the mixtard also. And he was using this, they told him to use this. And now separated the time, use this one this time, use this one the other time. From 14 millimole per liter, I think the fasting blood sugar, the next morning, it came down to 8. Now, this is what we do as a clinical pharmacist. What do we do as clinical pharmacists? We provide pharmaceutical care, responsible provision of drug therapy for the purpose of achieving definite outcomes that improves patient quality of life. In that case, we have drug therapy, but there is problem. So we need to do something to improve the drug therapy problem. Yes, we may not influence the initiation of treatment for the patient, but also the continuous management. And when there is problem along the way, we suggest and we discuss and we come up with solution. As clinical pharmacists, we pledge to advance direct patient care through clinical pharmacy. As clinical oncology pharmacy specialists, we pledge to advance direct cancer patient care through pharmacotherapy. And this pharmacotherapy is any pharmacotherapeutic option, chemotherapy or targeted therapy. And here is our principal pharmaceutical care. I will not waste much time here. Professional relationship to be established so that we provide patient-specific medical, we gather patient-specific medical information, then we provide the relevant information to patient. We assure the patient that the patient has all the information required for that drug therapy plan. Then we review, monitor, modify therapeutic plan necessary and appropriate. This is how we do it. I brought different forms of documenting pharmaceutical care plan deliberately because mostly we're normally confused. Okay, is it SOAP note or farm note or PCNE? What do we do? It doesn't matter. What matters is what you do. You can see that all of them, whether you assess drug therapy need and identify DTPs in the first one, second one, you identify DTPs, third one, you identify DTPs. The other one, assessment, that is where you identify DTPs. The last one, you look at the problems, that is the drug therapy problem. Then you develop care plan. The plan, so it doesn't matter how much it is called. What matters is what you do. Did you know the patient problem? Did you assess the problem? Okay, you know the patient problem. You look at the options. You choose the best for the patient. You monitor the patient progress. At the end of the day, the patient gets better. That is it. So let me choose one for us, just for tonight. Identify DTPs, determination of the desired therapeutic outcome up to the 7th one. We're going to follow it. So that at the end of the day, let's say this is a pharmaceutical care documentation form in the patient folder where you say, okay, you saw DTP, for example, adverse drug reaction to adramycin, so adverse drug reaction, or alopecia. What is the desired therapeutic outcome? I want to minimize alopecia. What are the alternatives? Maybe you have 2 different drugs or cream that you will apply. So how do you individualize it? You choose one, the best that is for the patient. Identification of parameters to evaluate outcomes. Of course, you want to see whether the alopecia is resolved or not. Provision of patient education. You tell him that this your alopecia is likely going after 2 or 3 months. If it doesn't go, there is no problem. We can change to another one, etc. So how we do the things we do. That is the last aspect. And let me say I have like 10 minutes, despite starting late. And let us discuss this case as fast as possible so that the remaining time that we have, we use it for discussion and questions, which is more important to us, because that is where we share our experiences. We have Mrs. R.A. It's a real case collected from one of the teaching hospitals. That 5-year-old married woman reported to oncology with swollen left breast. Her weight is this, and body surface area is this meter square, 1.6 meter square. She's self-employed. History of present illness condition started with a lump 2 months ago. She had lumpectomy 8 months ago by one of the medical officers in one of the secondary health facility. Past medical history, no any chronic diseases, but treated malaria 3 weeks ago. Family history, no non-positive family history of breast CA. Social history, she is a non-smoker and do not take alcohol beverages. Medication history, she denied any herbal medicine use, but uses diclofenac or cocodamol when necessary for pain, and also bromazepam to sleep when necessary. This is to show you how much the cancer must have affected her. She don't have any non-drug allergy. Her condition, she's responsive, but in obvious distress. This is her blood pressure, pulse rate, temperature. The skin is warm and dry. So we have some investigations. Histopathology suggested investigative ductal carcinoma. Cancer has been diagnosed. And they did a staging that shows the tumor size 4. I think that is the maximum. 2 lymph node involvement, no metastasis. That is stage 3B. We have full blood count, serum, EUCR, LFT, all essentially normal. The IHC suggested ER negative, PR negative, HER2 negative, with positive lymph node involvement. So this is classical triple negative breast cancer. So SOAPing, let's say SOAPing. Most of us are used to SOAPing, SOAP notes. We have the subjective and objective data previously. So let's see what is our assessment. These are not the right answers. It's not an examination. So these are some of the responses, I think, what the patient may benefit from, so that we can discuss more about that and share more idea. It is a triple negative breast cancer requiring optimal treatment or management. Let's mention that triple negative breast cancer normally is the most aggressive and is associated with the poorest prognosis. Sadly, it is what is affecting most of the Black communities. That is why our breast cancer develop more rapidly, and it also has more poor prognosis. One of the reasons is because, please can we unmute, can we mute Ubaidullah, something like that? So one of the reasons is because triple negative breast cancer, there is no target. There is no receptor like estrogen receptor that you give tamoxifen. There is no hematoepidermal growth factor receptor that you give trastuzumab to target and to have a better prognosis. So now what are the desired therapeutic outcomes? We would love to eradicate the tumor completely. Yes. We want to conserve the breast. Yes. Most women will not want radical mastectomy. They don't want to lose their breast. So breast conservative surgery is normally the best and it has more benefit. There is no difference between breast conservative. There's no additional benefit between radical mastectomy and breast conservative surgery by many studies. We want to prevent progression, like that is from stage 3B to stage 4, that is metastasis. We want to improve her quality of life. We want to minimize treatment-related side effects. We want to prolong her survival eventually. That is the ultimate goal of cancer treatment. What are our alternatives? Surgery, will she benefit from surgery? Yes, because the tumor is large. Normally in stage 3, you need surgery. The question is, can she go for surgery directly or she need chemotherapy or radiotherapy? Normally, stage 3 patient will need what we call neoadjuvant chemotherapy. Give the chemotherapy first so that you downstage, shrink the cancer, then there will be surgery. After surgery, you can give adjuvant chemotherapy to follow it up. Then later, maybe you can have radiotherapy also. So one of the options. Yes, we just mentioned she can benefit from radiotherapy. How about targeted therapy? It is triple negative disease. Now, let us see what we will choose for her. Because these are the therapeutic alternative. Let us design an optimal therapeutic individualized plan for her. Number one, we need neoadjuvant chemotherapy with either anthracyclines, that is doxorubicin, that is adriamycin or epirubicin, plus or minus taxanes, either docetaxel or paclitaxel, then plus or minus one of these, either the platinum, cisplatin, carboplatin, or the cyclophosphamide. So mostly you see that we use the anthracycline with cyclophosphamide either concurrently, that is, you give the 3 at the same time, or sequentially. One of the recent and most common practice is you give the AC, anthracycline, cyclophosphamide, maybe 3 cycles, shrink the cancer, take the patient for surgery. After surgery, you give adjuvant chemotherapy, that is the taxanes, maybe 3 cycles. Then later, the patient could come for radiotherapy. The surgery, after neoadjuvant chemotherapy, the patient will benefit from either modified radical mastectomy, probably. Then after that, the patient may or may not have the adjuvant radiotherapy, that is external beam radiotherapy. Let's not bore you too much. Let's go further and see what are the parameters can we use to evaluate outcomes. Let us monitoring for therapeutic response, how well the patient is moving. Tumor size, if the tumor size is reducing, then the patient is responding to treatment. How about the symptoms, the pain, the distress, the poor sleeping pattern, and so on? This PCR, not polymerase chain reaction, but pathological complete response or pathological complete remission, where after your adjuvant chemotherapy, during surgery, you take a sample, and mostly you see that pathologically, you can declare that the cancer is gone or not, okay? Then another thing is quality of life, of course, how the patient is doing. In fact, it is the most important thing. Then disease-free survival, how long will the patient survive without disease or recurrence? Then overall survival, which is the ultimate goal. Monitoring for toxic effect. We need to monitor the full blood count, whether any of the drug has effect on blood, hemolysis, and so on. EUCR, effect in kidney, the LFT, the echo. Mostly the platinums, okay, the platinums are monitored for LFT. We did one of the study that showed that platinum-based regimen normally have higher toxicity on the liver. They cause liver enzyme elevation. Sometimes, can we unmute? Can we mute Umoru? The chest X-ray, sometimes the taxanes are monitored whether they have a pulmonary toxicity. The echo, you use it sometimes to monitor the effect of anthracyclines on the heart. There, of course, we can monitor the
Hello, Dr. Aminu, are you still there? I think we may have lost Dr. Aminu again. I think we may have lost Dr. Aminu again. Depending when he will come, I'm sure he will come back online very soon. Depending when he will come back, just give a brief overview of what he has been talking. It's about breast cancer, management of breast cancer from the perspective of a clinical pharmacist. And like he said, breast cancer have the highest incidence in Nigeria. We have the highest incidence of breast cancer in Nigeria, over 28,000 cases. That's 22.7% of breast cancer incidence in Nigeria. He has talked about management. He talked about clinical guidelines. We have the National Comprehensive Cancer Network Guideline. We have the American Society of Clinical Oncology Guideline. We also talk about management, which include surgery, radiotherapy, targeted therapy, and chemotherapy. He also talked about staging of breast cancer, the TNM staging, and the molecular classification. Now, as clinical pharmacists, what's our role in the management of breast cancer? As clinical pharmacists, our role in the management of of breast cancer, we have to do pharmaceutical care management of breast cancer. In identifying ways of pharmaceutical care, we have to identify, because most of the drugs we use in breast cancer come with their individual side effects, comes with the drug therapy problem. We have to identify the drug therapy problem and ways of improving clinical outcomes for patients with breast cancer. Okay, let me share his slides. Now, like I said, most of the drugs available for breast cancer have their individual drug therapy problem. We have lots of side effects with anti-cancer medications. We have to identify which drug will be suitable for individual patient. He also talked about the HER2, identifying HER2, those that have HER2, positive or negative. Okay, Dr. Aminu, are you back on? Kindly unmute. Can you hear me, Dr. Aminu? Kindly unmute yourself.
Okay. Can you hear me now?
Yes, yes, we can
All
hear
right.
you.
Okay. I think we are concluding so that we can have our discussion session. Let's just go to the conclusive aspect. So here we provide patient education from different dimensions, and we communicate and document. So now I know that the idea of many pharmacists is, okay, all those things were mentioned, they are not pharmacists' job. Well, it is not true. But however, if you are among those, there are a lot of other things you can do. If you don't have the opportunity to do the real clinical pharmacy practice, where you see patient, assess patient drug therapy need and all those things, you can monitor clinically important drug-drug interactions. They gave a patient cytotoxic A and they're trying to give another one concurrently, you can raise an alarm, okay? Because you have to show interest in the patient, you have to visit, show commitment to learning, and also make your contribution. You can educate other caregivers on some unique properties and effects of commonly used drugs, especially the cytotoxic. This has this common side effect, and this is how to do it. You divide the dose. No, the dose is too much. You talk to the physicians because you know more about these drugs if you really have interest. Then who does the reconstitution? Many hospitals have oncology reconstitution where the pharmacist reconstitute those medicines. You just take it to those that will administer it, like the nurses. Then we need some level of research also, so that as you are there over time, you monitor how some group of patients are doing, so that you can, after some time, make a sound conclusion about that. We can introduce some novel alternatives through updated guidelines. Once you read a lot, you follow a lot of guidelines and updates, then you can just say, no, they don't normally use this anymore. When you do this, the patient will be better. You can also ensure the availability of drugs at a good quality and at affordable to the patient. We all know that these drugs are highly expensive. So you can interact with the patients to make their life better. For example, one of the things they do, a patient has, for example, 50 milligram of adramycin in one vial, and the patient will just need 20 milligram, and that's another patient needing 25 milligram. So why not make it possible for the two patients to buy a vial and share, so that you give each the appropriate dose, i.e. we are going to UDDS that will include and will minimize wastages, so on, and a lot of things we can do. So even when we do this, you realize that our oncology skills and practice over time will be developing, and we do that from just interest. So we can now conclude that management of breast cancer is complex from at least even the molecular classification. I'm sure I may not be able to pass the message to everybody, okay? And that the patient actually need the services of clinical oncology pharmacists, because no one else can fill their gaps. Nobody can ensure the uninterrupted availability and affordability of drugs. Skills that has to do with patient and drug monitoring, nobody has it better than a pharmacist if he's committed. Hence, pharmacists need to put more interest, and dedication to service, not just to come to work and stay in your office and expect that you'll be master of oncology. No, dedicated to service and learning. You can only serve when you learn, when you have the capacity to serve, and learning from every team member in the oncology team. Okay, sometimes you learn from the nurses, sometimes you learn from the physicians, sometimes you learn even from the ward attendant. But at the end of the day, if you are dedicated to seeking for knowledge, you realize that you actually know more than all of them. But you also learn from people because you don't know everything. In that way, we can ensure that we advance direct cancer patient care through pharmacotherapy. I always acknowledge CPAN for making sure that CPAN continues in Nigeria. I appreciate the ESCOs of this cancer oncology group for making sure that presentations like this go on despite having less capacity to present in this forum, I was just still contacted. They kept calling me and ensure that there is no failure. I will always remember my mentors for putting me through and making me know the little that I know. My professional colleagues also, then friends and family that helped me in developing this slide. We have some references. In breast cancer, we always say, or in cancer generally, early detection saves life. And I really, really thank you for listening despite all the hitches, network issues, starting late. And I hope you have benefited from this presentation. Thank you. Over to you, moderator.
Thank you very much, Dr. Aminu, for that wonderful presentation. Like I've said earlier on, talking about breast cancer, and like you said, management of breast cancer is complex. Understanding breast cancer is complex. But even with the complexity, we still have to understand breast cancer to be able to give the best pharmaceutical care to patients with breast cancer. Like I said earlier on, Nigeria unfortunately have the highest incidence of breast cancer, with over 28,000 cases of breast cancer. As pharmacists, we have to understand breast cancer. We have to understand medications involved, used in the management of breast cancer. We have to know the side effects with medications used in breast cancer. We have to know the guidelines in the management of breast cancer. We have to know the various combinations available for management of breast cancer. But first and foremost, we have to understand how to identify breast cancer. I'm sure each and every woman or man should know how to inspect the breast for the presence of breast cancer. Every person should know. And also pharmacists should also know, so that we can teach our patients, our friends, our family, ladies, how to inspect the breast to see if there's any lump. So like I said, management of breast cancer, guidelines involved in the management of breast cancer. We also need to know the drug therapy problems involved in each medications. He has said so much about management of breast cancer from the clinical pharmacist perspective. He has said so much about breast cancer. I hope we have taken a lot from this wonderful presentation. So the floor is now open for questions, comments, contributions. Okay, I see Dr. Williams.
Thank you so much, Dr. Aminu, for this beautiful presentation. As clinical pharmacists, our role is very unique. An area I want us to pay attention to has to do with patient education. You know, there's this stigma and state of denial that cancer patients usually exhibit. As pharmacists, we want to carry out a lot of patient education counseling so that if they are on medication, they'll be willing to accept the chemo and other antineoplastic agents that will be needed for the treatment. If we don't do our role very well, you find that after some time, they will just DAMA. And when they DAMA, we have failed. So that's a key area we need to pay attention to at the point of inception or contact with the pharmacy, oncology pharmacy. We want to do the needful so that we're able to give the right care, the right attention to these patients. Thank you.
Thank you, Dr. Williams. The patient, that cannot be overemphasized. We need to educate our patient. We need to educate our friends and family about breast cancer and with stigmatization. Like she said, if they are not taking their if they don't understand breast cancer, if they feel stigmatized, they may not take their medications, they may, discharge against medical advice from the clinic. So it's very, very important to educate our patients on how to inspect the breast, patient education generally on breast cancer. Thank you very much, Dr. Williams. We have a question here on the chat box from Mrs. Raymond Okechukwu. He's saying, what precisely is targeted therapy and dose dense?
Okay, I think I like that. Let me respond to that so that we can also, before we continue taking comments. Breast cancer therapy, we have the surgery, we all know about that. We have the chemotherapy, we know about that. We have the radiotherapy. You put radiation, you burn the cancer cells, that is it. But targeted therapy, you are targeting a particular thing that contributes to the cancer cell proliferation. For example, the estrogen receptor. When you take a sample of the cancer tissue and you do your immunohistochemistry, pathologists will check it out. They say, okay, these cancer cells have estrogen receptor that help them to proliferate. So now you say, okay, now let me give a hormonal therapy. Estrogen is a hormone. You give hormonal therapy that reduces that expression so that the proliferation of the cancer cell will also be reduced. Another thing that we target is progesterone receptor. So all those ones, they are hormones. Another good target is the human epidermal growth factor receptor 2. Okay, expression. So it's also a receptor that, okay, when a cancer cell has, it helps it to proliferate very well. So when you give something against it, then you are targeting that particular biomarker. Those dense, on the other hand, there are a lot of methods of giving chemotherapy. You can give concurrent. Let's use this adramycin cyclophosphamide paclitaxel. Okay, so you can give it concurrently. Give 6 cycles of 3, each cycle 3 weeks for 6 cycles, for example. You can also give it sequentially. Let me give adramycin cyclophosphamide, maybe for 4 cycles. Then I will follow it up with maybe just paclitaxel for 2 or 3 cycles. That is sequential. Studies have shown that there is not much difference between the benefit of sequential and concurrent therapy. And at the end of the day, there is reduction in cost, reduction in side effects on the patient. But those dense, on the other hand, if you give the chemotherapy, for example, 3 weeks, you can decide for 6 cycles. You can say, okay, let us give it 2 weeks, compress the number of days. But in this case, we just give it for 4 cycles. Studies have shown that that one is also effective, and the benefit is as good as giving it for those 6 cycles. But for which cancer, it depends. Is it triple negative? Is it stage 3 breast cancer, locally advanced? Is it early breast cancer? We should note that every subtype of breast cancer has its own treatment protocol. So one of the things we'll be looking at later is, okay, we want to discuss cancer, what type, management of early breast cancer, or the utilization of monoclonals like trastuzumab in the management of breast cancer. We talk about all their benefits. Or we go in and say, okay, we want to see how chemotherapy can benefit patients with locally advanced breast cancer, or management of metastatic disease, okay? Or the use of palliative chemotherapy. You use it, you give the alternative, okay, palliative chemotherapy. When probably the options are limited and the prognosis is poor, you give palliative. So all those things are different modalities of management of cancer, and that is why discussions like this, we do it and give ourselves more awareness. But then there are more to it than what we present. I think let me allow for more comments to come in before let me not talk too much.
Okay, thank you very much for that reply. Okay, yes. Okay, somebody's asking.
Okay, getting the slide.
Yes,
I think
absolutely. We'll share the slides on the platform after the,
on the
presentation.
Yes. All right.
Any other question, comment, contribution?
I think it's already 10:30. With or without the presentation, we have to assume people are tired. So if we don't have more comments, we can wrap it up. Okay,
all right. Thank you everybody for attending this tonight's presentation. I know that we have gained a lot of knowledge from this presentation about breast cancer, about pharmaceutical care, the role of clinical pharmacists in the management of breast cancer. And we need more people involved in breast cancer to show awareness, to be involved in oncology. We have, yes, the oncology, I know breast cancer is, oncology itself is complex. The management is also complex, but we have to understand the management, we have to understand the disease, we have to understand the pathophysiology for better management of our patients with cancer. In the absence of any, okay, all right. In the absence of any question, comment, or contribution, we thank everybody for attending to this presentation. We thank everybody for attending today's presentation, and we hope to see you next time during the next oncology presentation. Thank you, everybody.
Thank you all. Good night.
Good night.